Dr. Dustin Briggs here from Desert Orthopedic, who is going to be talking to us about the ABCs of cartilage. And he'll tell you more about the presentation itself. But hold on one sec here. Make sure I got volume up. We will make sure that everybody is in the room before we start. And then we'll have a presentation. We'll have a video, hopefully, if we can get it working here. And then just know that we are recording this, and then we will have it edited, and we will play it and have it resent out to everyone who registered. We will also then have it on our Eisenhower Health YouTube channel. We will also have it on our Eisenhower Health website, and will also be under Desert Orthopedic. So a lot of places to be able to look at this after the fact, but if you did register through Eisenhower, which I think most everybody did, I will also email it out to everyone once it is edited and ready to go. With that in mind, I'm happy to present one of our specialists here from Desert Orthopedic, Dr. Briggs, and I'll let him introduce himself, and then we'll get moving.
All right, yeah, thank you very much, Brett. I'm Dustin Briggs. I'm one of the total joint replacement surgeons at DOC. And in the past, I've kind of given some lectures mostly about surgery and robotic surgery and the recovery and expectations. But today I decided to go more of a scientific route. I get a lot of questions about what is arthritis, what are the treatments for arthritis, and then I hear a lot of myths about treatment options and what you can do to cure it or prevent it. So we're going to go through some of those today. This is kind of how the talk started. I was sitting trying to think of a topic, and about a month ago, one of my best friends from medical school sent me this article via text, 3 words that cause harm, bone on bone. And I stopped and thought, how many times do I tell patients they have bone on bone arthritis every single day? And this article was basically saying how it's a detriment. The patients hear those words, they feel like their knee is going to crumble, they stop doing activity, they become depressed, they become sedentary, and it causes a big problem. And prior to reading this, it's so frequently addressed in our clinic that I hadn't thought of it that way. And so my friend Tim, who's he's a primary care, kind of a functional medicine specialist, sent me this article. And at first I was kind of put off by it. It's like, well, we have to tell patients the truth. They have bone on bone. We treat it accordingly. Some are surgical candidates. And as I read the article, I realized that it really can have an effect on someone's quality of life. So I agreed with him. I did think it was a great article. But also said that, total knee replacements are pretty remarkable. So also, when I got to seeing it, I saw a bunch of posts on Instagram. So there is a pretty big community on Instagram of orthopedic surgeons kind of sharing cases and getting advice. And one of the trusted doctors is Dr. Marichek. He's an orthopedic trauma surgeon at Cedars-Sinai in LA. And then down lower, we have Dr. Earhart. He's a trauma surgeon in Chicago. So Dr. Marichek posted a pretty pointed post noting certain notable physicians here in LA are advocating stem cell treatments online. And he went on to say there are no FDA-approved stem cell therapies for orthopedic conditions. So either the treatment advertised is misleading or illegal. So today I thought I would talk mostly about cartilage, everything to do with cartilage. What is arthritis? What biological treatments do we have, and how should those treatments be marketed and discussed? And then again, common myths. So there was a nice discussion following this post. Kind of Dr. Marichek, Dr. Earhart, and others are going back and forth to say that, a lot of us do use stem cell type of products, but it's the marketing, it's the concepts, it's what's promised with these injections that becomes the problems. And so we'll go on to discuss that in great detail during this lecture. Hopefully it's not too scientific, hopefully it's not too dry, and a Zoom format is a little difficult with no interaction, but we'll give it a go. So in general, what is cartilage? I talk about cartilage every single day. From a big picture, arthritis is really just wearing out of the cartilage. Specific to the knee, there are three types of cartilage. There's fibroelastic cartilage, which you may hear referred to as the meniscus in the knee or the labrum in the hip and the shoulder. And then there's fibrocartilage, which are the tendons and the ligaments. And then today we're going to talk mostly about the hyaline cartilage or the articular cartilage. That is the covering of the cartilage where two bones meet in the body, which allows for a smooth surface. So with regard to the knee, this is looking down straight on the tibia. Can I see my pointer if I point here or no? Is the pointer visible?
You cannot, no.
Okay, no. So there's rings of cartilage on the edges here, and those are the meniscus, and then the smooth between the rings is the articular cartilage. And I always say that the femur is round and the tibia is flat, and a round on flat mating is no good. So the meniscus compensates for that round on flat mating and makes it a nice congruent articulation between the femur and the tibia. So the function of cartilage, as we said, is basically to act as a shock absorber. So it decreases the friction and also distributes the load. And this is a nice picture that basically shows the three areas in the knee that rub. So you have the kneecap rubbing on top of the femur, and then you have the femur sitting on top of the tibia, and we call that the medial compartment on the inside of the knee and the lateral compartment on the outside part of the knee. So any of those areas can cause arthritis, medial, lateral, or anterior, which is the patellofemoral joint. Cartilage likes to be physiologically loaded. It likes to be weight-bearing, and it likes to move. That helps nourish the cartilage. It helps it do its function. But a supraphysiologic or a non-physiologic load that causes an injury is typically what starts this process of post-traumatic arthritis that we'll also discuss down the road. So now we're honing in on real basic science. So back here we saw the picture from a big scale of the cartilage, and now we're looking really under the microscope. So on the left, that picture shows the layers of the cartilage. So down in the bottom, we have the cancellous bone, which is the bone at the end of the bone right at the end of the bone. And then on top of that is what's called the subchondral bone, which is a very, very firm layer of bone that supports the cartilage. And from up there to the top, the superficial zone, that's only about 2 or 3 millimeters. So the topmost layer, the parallels of cartilage are rubbing the fibers of the cartilage are rubbing parallel, so that acts as a nice gliding surface. And just below that, the fibers are running perpendicular, so that offers support. In the picture on the right, this it's sort of a gross specimen, we call it, where you slice through it and look under the microscope. Those little black dots distributed in there are what we call the chondrocytes, the cells of the cartilage. So there aren't that many cells in cartilage, and we'll talk about what makes up the cartilage next. So cartilage is mostly water. It's 65 to 80% water. And then it's made up of collagen, which is like the elastic material in our body that makes up our ligaments, skin. It's the building blocks of your what we call your connective tissues. And then proteoglycans, proteo means protein, glycan means glucose. So it's a combination of a protein and a glucose molecule that build together, and those absorb water. So those are what helps hold the water in the cartilage. And then the cells make up a very, very small portion. We're eventually going to come back to this model of what the proteoglycans look like, but we'll go back to hyaluronic acid. So hyaluronic acid is the backbone to which these proteoglycans attach and allow the cartilage to contain water. So I know we're getting deep into it here. Normally we do big picture type talks, but this one's going to get kind of deep, and then we're going to step back again and look at kind of what arthritis is big picture. So from a microscopic standpoint, we know the articular makeup. We know the makeup of the cartilage. In this picture, where the arrow is, that is an area that we would say bone on bone. The rest of the knee looks normal. So I hope this isn't too visual, but this is what we see in surgery when we do the knee replacement. The X-ray correlation of that is here on the left. where these bones here, where the arrows are rubbing bone on bone, whereas there's nice space on the other side of the knee in the lateral compartment. And that correlates with normal cartilage in the picture versus the abnormal cartilage on the other side. So we often say it's wear and tear, but really it's more than just a mechanical process. It's mostly chemically related. It's caused by inflammation. Inflammatory particles called cytokines get attracted, and a lot of these inflammatory markers help healing, but a lot of them are bad players and cause progression of arthritis. I see a lot of patients in clinic that have had an MRI and they get concerned about their meniscus. But as the cartilage erodes and it exposes the bone, that is a very irregular, not a smooth surface, and that tends to cause degenerative meniscus tears. So addressing a degenerative meniscus tear in the context of arthritis really won't help very much. So that's why we don't offer arthroscopic surgery, which trims up the meniscus very often when the arthritis is severe. So in general, arthro means joint, itis means inflammation. So it truly is inflammation of the joint. And over time, as we age, the cartilage actually gets thin, but a lot of people have normal cartilage throughout their entire lifetime. But if an inflammatory cascade takes place for a number of different reasons, that can lead to arthritis, which is one of the big focuses of today's talks. That's what we hope that some of the biologic injections can intervene with, kind of stop that cascade of progressive inflammation causing progressive arthritis. Arthritis is very fickle. It is an incredible structure. It is so smooth, but it also has no blood flow and it has no nerves. So it gets all of its nourishment from the underlying subchondral bone, and more importantly, the synovial fluid, which is the fluid that is contained within the joint. Unfortunately for cartilage, there's no regenerative or healing potential. So when you lose it, it's gone. So what does this look like in clinic when you come and see us? We get x-rays on everybody. We make sure we get weight-bearing x-rays, which I will show you in the next few slides. So if you're seeing your primary care doctor for knee pain, make sure you get weight-bearing x-rays to really accurately assess the joint. So we look for the 4 S's of arthritis: joint space narrowing, subchondral sclerosis. When the cartilage gets thin, the underlying subchondral bone sees more pressure than it's used to or that it should, and it becomes very thick and turns white on the x-ray. We call that sclerosis. We look for cysts in the bone. The cartilage is a nice protective layer between the synovial fluid and the bone, and when the cartilage gets disrupted, the synovial fluid can actually penetrate into the bone and causes cysts. And then bone spurs. We mentioned before that cartilage distributes the force in the knee. Bone spurs are the body's way of trying to make up for the lack of cartilage, and it tries to disperse the force farther across the bone and makes kind of extensions of the bone beyond the joint. We call those bone spurs. So this is an x-ray of one of my patients, and this just mostly shows the importance of having a weight-bearing x-ray. So we took the name off the x-rays, but this is an x-ray before he came and saw me, and it's a non-weight-bearing x-ray. And if you look in the inside part of the knee, I wish I had a pointer, but I don't. It's on the right side of the screen is the inside part of the knee. You can still see that there's space there. And then the next set of x-rays is a weight-bearing x-ray. And in comparison, where there's pretty good space here on the inside part of the knee, here it's starting to get very, very thin. But there's one special x-ray that we get that's called a PA flexed view, which means we take an x-ray from back to front. So you're standing with your back to the x-ray machine, and you bend your knee down a little bit. And you can now clearly see that that is bone on bone, no cartilage protecting those bones. So it goes from relatively normal looking x-rays, non-weight bearing, to some moderate arthritis, weight bearing, to clearly severe arthritis. These are within days of each other. So it's not like the disease progressed. It's just that the x-ray has some x-rays are better at picking up on it than others. So now we're going to get into the meat of the discussion here. So you've seen the doctor. They may say you have bone-on-bone arthritis. You go home, you don't know what to do. You're going to totally change your lifestyle to protect your knee. But I hope that doesn't happen. I hope today's talk gives you hope that there are some interventions we can do, or at least you'll be better educated as far as what those are. So for the most part, there are three main types of injections. The mainstay of injections are cortisone, which is an anti-inflammatory injection, which blocks that inflammatory cascade, blocking the cytokines and other harmful inflammatory chemicals. And then we'll talk about hyaluronic acid. We've already briefly touched on what hyaluronic acid is. Again, it's that molecule that acts as a backbone so the proteoglycans can attach to it and the cartilage can function normally. And then we'll talk about the general biologic injections, and that's the B of the ABCs. So the two main types of biologic injections are PRP and stem cells. And we'll spend a lot of time on stem cell injections today, just because I get a ton of questions about that. It is a very complex topic. I am by no means an expert, and really there are very few experts because this, it's in its relative infancy. There's a lot to be learned, and we don't exactly know how to describe it to patients. There's still a lot of data that need to be collected. So the first line for injections is typically corticosteroid, and that's because it's been tried and true for many, many years. It's a potent anti-inflammatory that can block the inflammatory cascade. Corticosteroid injections do not reverse arthritis. Some people think of them as a Band-Aid, which is somewhat true, but I have a lot of patients concerned that they're going to mask the pain of their arthritis. And really, there's not much downside to that. We'll talk later that activity does not correlate to arthritis. It's actually the opposite. Being active, having physiologic load in the joints, actually is very, very healthy for the cartilage. So if you can tolerate it, you're doing no harm. I always tell patients activity might be hurting you, but you're not hurting your knee. So when is some of the main points of this article, compared with corticosteroid injections for arthritis, intra-articular viscose lipids, that's the hyaluronic acid injections, have not shown a substantial difference in pain relief or functional outcomes. So that's why a lot of us go with corticosteroid for first line. It is relatively inexpensive, it's covered by insurance, and it's effective. The problem is it can be relatively short-lived. We hope that it lasts about 3 months. We typically take 3 months between injections. And some folks have a concern of if it's degenerative or it's detrimental to the cartilage. And the answer simply is we don't think so, but we don't absolutely know. Arthritis is progressive in nature, meaning it gets worse with time. And the rate of progression is impossible to predict. So if you have an intervention that causes pain relief, but at the same time, the natural history of that disease is to get worse, it's difficult to tell whether that arthritis is worsening just because arthritis gets worse, or if cortisone is accelerating that process. We don't think it does. Some of it may be secondary to the anesthetic that's used, although results on that are mixed as well. So we certainly think we're helping people with corticosteroids. We wouldn't be doing it otherwise, but we do use it judiciously. We take 3 months between the injections. And most importantly, if you go on to have a knee replacement, there should be 3 months between your most recent injection and the knee replacement to decrease the risk of any associated infection that may result from the surgery. So we're back to that molecule that looks kind of frightening, but the hyaluronic acid. So I often get, I want that rooster comb injection. So hyaluronic acid initially was first sort of isolated from the rooster comb. It's an natural avian product, some bird product. So again, it's the backbone of what the proteoglycans attach to. So the thought is, while it doesn't reverse or cure the arthritis, it could improve the milieu, they call it, kind of the general environment of the knee to restore it back to more of its natural form. We do often refer to it as a gel. I don't want anyone to kind of misinterpret that it acts like a cushion or offers like a pad to the knee. It functions from a chemical standpoint, not from a mechanical standpoint. So there are lots and lots of articles on hyaluronic acid, and it can be difficult to tease out the literature because many of them are industry-based, meaning there's a bias to those articles. The company obviously wants to show results for their knee. So there can be a lot of bias in these articles. For the most part, we do think that hyaluronic acid is effective. But as we will see with many of these next slides, injections in general are pretty effective, even if it's saline. And whether that's because of placebo or a true change in the interarticular environment, we don't exactly know. But this article was written in the Journal of Bone and Joint Surgery, which is one of our main trusted articles. It went on to say that the avian-derived HA injections, those tend to have higher side effects. They can cause what's called pseudosepsis, which looks like the knee's infected, but it's really not. It's just highly inflamed. So most of us use a synthetic derivative now that's not derived from a bird. So Euflexa, which is one that we commonly use, it's a 3-shot series. It was shown to have the lowest adverse effects and good patient improvement. So this article, I just posted the abstract here, but in the media of the article, they identified 17 meta-analysis. And meta-analysis is basically, it's an author that searches the literature looking for works that are most accurate to explain the question they have. And so they identified 17 of these separate meta-analysis. So the data was huge. 13 of these sort of big picture studies showed improvement compared to placebo. 2 showed detrimental effects compared to placebo, and 2 were inconclusive. So out of 17 sort of summary studies, 13 showed improvement. So we do use HA injections quite frequently. This article goes on to address the cost. So we will get into the cost of PRP injections and stem cell injections because those are out of pocket. And obviously that cost is going to directly hit your wallet. HA injections, for the most part, are covered by insurance. There are some insurance companies that don't approve HA injections, somewhat because of articles like this. But this article claims that the outcomes are controversial with mixed results, and then it is expensive. So about 15% of patients within 1 year of surgery in this study had an HA injection. And this is what we call kind of a database study, where we look at all the submitted billing from clinical, outpatient clinics. And so it's huge numbers, like hundreds of thousands of patients. So 15% of patients had an HA injection prior to their total knee. And other than the imaging required to look at the patient, it was the second highest cost for these insurance companies. So only 15% of patients got the injection, but it was 16% of the overall cost of non-operative treatment of knee arthritis. So it is a big burden of cost for Medicare. So we do cortisone injections as a mainstay. Those are relatively ineffective. They've been around for years and years, and they work really well. They don't do anything to change the natural history of arthritis, meaning it's progressive. The cortisone treats the pain, but doesn't change the disease process. Same with hyaluronic acid. The pain relief we think might be a little longer, although it's a little more hit or miss as to whether patients are going to benefit from it. So now we're going to look at these biologic treatments, and kind of related to that Instagram post, it's a slippery slope. We want to make our patients better, but now we're talking about cash pay. It becomes kind of the business of orthopedics. And we all know how, our patients trust us. They put trust in us to do the right thing. And that's something I take very seriously. And so I want to be open about biologics and if it's worth the money and if you should do it. So platelet-rich plasma and stem cells, I say that in quotes, which we're going to get into, are the two main types of biologics. The hope is that these can actually change the disease process, which cortisone and HA don't do. There is no way to regrow cartilage or reverse the arthritis. And these two products should not be claimed to do that. They don't do that. They might halt the progression of arthritis, which even that would actually be a big improvement from what we have right now. So we're going to get into the details. So platelet-rich plasma, this is how it's obtained. We collect a blood sample, just normal blood, like we were drawing your blood. It gets centrifuged, just spun really, really fast. And we separate out the platelets. And so it basically gets the red blood cells, it gets platelets, and it gets plasma. And there's a thin layer that has what we want, the platelet-rich plasma. So that's aspirated, and that's injected into the knee. Now, the belief is that has healing components. So your body, if you get an injury, it sends a ton of blood flow to that injury, and it's because it's trying to pound it with healing, it's a healing process. The hope is that the isolated, well, we know how to spin it down so that the products isolated are of positive healing potential. The title of this article is related to bone marrow aspirate, which we'll talk about. That's actually a more accurate name for stem cells. But I pulled out a paragraph from this article talking just about PRP. So don't be confused by the title of the article. This actually is about platelet-rich, plasma. So they looked at several studies, 8 of which were high quality and 1 of which was moderate quality. And the groups that received PRP as opposed to saline or placebo injections showed improvement in patient-reported outcomes. I have never done a PRP injection. There are many providers in my practice that do the PRP injections. I do indicate patients often or recommend it to patients, but I have other providers in our clinic or in our hospital system do the actual injection. But I do think that there's a potential for improvement with PRP injections. Again, it is out of pocket. So now we're going to kind of so that was more of an introduction to get to this point. Like, what is the stem cell? Is it worth the money? What's all the hype? And, what's in hold for the future? So a mesenchymal stem cell is a cell that can differentiate into the connective tissue. So that's the chondrocytes that make cartilage. It's the osteoblasts that make bone. It's the myoblasts that make muscle. It's the neurons that make the nerves. It's the fibroblasts that make all the connective tissue we talked about, the tendons, the ligaments. So one cell line, depending how your body treats it with chemicals, can differentiate into all those different types of cells. So we say that it's a pluripotent cell, meaning one master cell can become any of these other cells depending on what chemicals it receives from your body. Now, that would be awesome if that actually happened with an injection, but unfortunately that doesn't happen. This is how we get created from an egg to a human through a process regulated by your body. But unfortunately, by us injecting a stem cell into your knee, it cannot differentiate like this. And so anyone who claims that it can be differentiated like this is we don't have that technology yet. So unfortunately, by injecting mesenchymal stem cells into your knee, they don't magically become chondrocytes, which then magically make new cartilage. If we had that, that would be awesome, but we just simply don't. So on the left here, it's a pictogram of how the stem cells are obtained. So we talked about PRP. You aspirate your blood, spin it down. This is very, very similar. So we either get it from bone marrow or from fat. So a bone marrow aspiration, they actually have to stick a needle into the bone. It's usually right in the back of your pelvis. We aspirate essentially bone marrow. It's hard to say we're aspirating bone marrow, but it's blood that has the marrow elements in it. We spin it down very much similar to the PRP. It gets expanded into stem cells and then injected. The other option is to do what's called lipoaspiration. It's essentially like a little mini liposuction, but it gets fat-derived mesenchymal stem cells. And again, those are expanded or grown, and then those are injected. So this is a good kind of a general review article for stem cell therapy for the treatment of the knees. And in general, I'll just read: the mesenchymal stem cells have immunosuppressive and anti-inflammatory properties that aim to modify the disease process. Patients find improvement in function and pain after MSC therapy, and MSC treatment stabilizes the cartilage, but there is no definitive regeneration. So just like we've talked about, the goal is to halt the process of progressive inflammation and degeneration, but thus far we have nothing that reverses the process and regenerates the cartilage. So later in this study, they claim that the average individual diagnosed with knee arthritis spends about $15,000 related to the medical cost of that knee arthritis over their lifetime. So obviously it's a big deal. It's a financial burden. It's a quality of life burden. Here it's a pickleball burden. People want to get back to playing pickleball and golf, and I completely understand. I'm very active, and we want to get our patients back out and active too. One of the lines I liked in this article is that interarticular delivery of MSCs to articular cartilage provides growth factors and extracellular matrix proteins which aid in the halting of the disease process. This is another review article of bone marrow aspirate. So that brings me to the point where it's better not to call them stem cells. Stem cells gives the impression that it's a pluripotent cell that, when injected, converts to chondrocytes, which convert to cartilage. So we don't want to falsely advertise this. A much better name would be concentrated bone marrow aspirate, because that's how you obtain it, and that's what it is. It doesn't actually obtain the pluripotent cells, but it does have really, really good chemicals that we know modify the disease process. If we can get the video, which I think we hopefully can, it's not quite yet, but I have the founder of stem cells who is walking back on the name of stem cells as it relates to knee arthritis. This article basically says that this research is very much in its infancy. So this article is from 2023. And you can see there's a systemic literature review of 12 articles, only 3 of which were noted to be high quality. So we really just don't have high quality evidence to be able to strongly support its use, or to be able to give, well-educated recommendations to our patients. Of those articles, these were 2 that we're coming up on that I just took a deeper dive into because I felt like they were well-designed articles. This is the kind of article that we need to give us good information to relay to our patients. So this is what we call a randomized controlled trial. So a patient volunteers for the study, but they don't know whether they're getting the intervention or a placebo. In this case, it was really nice because the patient is their own control, which means one of the knees got injected with the BMAC, the bone marrow aspirate concentrate, and the other one got injected with saline. And the patient wasn't told which one was which. And interestingly, so there were 25 patients, one knee got saline, one knee got BMAC. The patients all got better, but both knees got better. So there were no serious adverse events. The pain and visual analogs pain scores in both knees decreased significantly from baseline at 1 week, 3 months, and 6 years. The pain relief, although dramatic, did not differ significantly between treated knees. So what do we take from this article? I really don't know. The saline injected knee did just as well as the BMAC injected knee. It does say that they're safe. Similarly, this is probably the same patient population, 25 patients, One knee injected BMAC, the other knee injected saline. And they did an MRI, a follow-up MRI. And not surprisingly, because we know that there's no regenerative potential, the MRI was not changed. So that confirms that there's no regenerative potential. Oh, I didn't realize it was. I just now realized that it's sharing this exact view with everybody as opposed to the slideshow view with no notes. So they're seeing the same thing. Oh, sorry. Here, I can actually, let me exit the presenter view.
So all we're seeing right
so
now
it's-
is just a photo of the.
Oh, you are? Oh, okay.
snapshots.
Okay,
We're not
good.
seeing your notes.
Good. You're not, okay.
Nope. it's
Perfect.
all
No problem. Okay, so this article, so sorry about that. Mostly what he's saying, he has a really cool line in there where when he discovered mesenchymal stem cells, he could make a cell dance, is what he called it. He could, depending how they, the environment they put it in, that cell would turn into whatever environment it was. So again, a chondrocyte would make cartilage, it would turn into a chondrocyte in the context of cartilage and osteoblast. But he goes on to explain that while that happened in the lab, and while that is a natural process in our body, he is unable to get that process to happen through a stem cell injection. So he begged everyone to stop calling them stem cells, and at least call them mesenchymal stem cells. But really, a BMAC or a bone marrow aspirate concentrate is a much, much better name to call it, or a adipose-derived mesenchymal cell. Those are much more accurate than a stem cell, because again, these are not pluripotent cells that turn into new cartilage. So we talked that PRP, so cortisone and HA injections are covered by insurance for the most part. PRP and BMAC are out of pocket. They're not covered by insurance. And so again, this is a bit the business of medicine. And so in South Florida, they looked at all the orthopedic surgeons in South Florida, Miami-Dade County. They contacted 95% of the orthopedic surgeons there, which was out of 96 offices or 96 surgeons. 36%, so about 1/3 offered PRP, and about 1/4, 25% offered stem cells. Interestingly, 81% of them were transparent about PRP pricing, which is about $900. That's pretty similar to what we charge too. And again, not all of that, most of that's not profit. It's an expensive kit to make it. So it is an expensive just process in general. But 42%, they were only transparent 42% of the time about the pricing of stem cell therapy, and it's about $3,000. So there's a little bit of what's behind the screen for stem cells as far as how much they cost. There's a huge variability, anywhere from $1,000 to $10,000. So stem cell therapy right now is a little bit like the wild, wild west. The analogy is kind of like NIL in college football. Like, it's a really good philosophy to play the players because it's a billion-dollar industry, but the rules of how to do so are being constructed, in real time. And that's very much similar to stem cell therapy. I do think there is huge potential for stem cell therapy, BMAC therapy, but we're discovering it as we go, and it is expensive. So switching gears a little bit, that was what I wanted to focus on, biologics. I hope that helps get a better idea. I'll give an overview at the end as well again. But there's common myths like we talked about. So there's the arthritis, which is the B, there's arthritis, which is the A, biologics, which is the B, and now we're going to come into the common myths. So I see a ton of patients who have been active all my life. It's catching up to me now. I finally have arthritis. I wore my joints out. Thankfully, it's just the opposite. Moderate physiologic exercise is tremendously healthy for your joints, and keep it up. In fact, moderate running increases cartilage thickness and proteoglycan content. Now, the danger is strenuous loading, and this strenuous loading is like just close to or causing injury. So it's, your body's in a bad position, or it's just too much weight. but the strenuous load causes cartilage thinning and proteoglycan loss. It's pretty hard to get a super physiologic load that causes injury, but it certainly can happen. With running sports, jumping sports, things like that. But we also know that immobilization leads to cartilage thinning, softening, and proteoglycan loss. So big picture, stay as active as you can. I know there's a lot of recent published, data and articles about like rates of pickleball injury. But on the flip side, in general, if pickleball gets a big number of people to be more active and more healthy, while there might be a small few number of injuries, big picture, it's healthy. It provides a good, social foundation for people. It's fun to stay active. It's fun to be outside. It's healthy. So in general, I think it's a great sport. This article confirms that, being active, even to the extent of marathon running, is not bad for your joints. There's actually a very low prevalence of hip and knee arthritis in active marathon runners. So while the average age in this study was only 48, the age ranged anywhere from 18 to 79 years. And the marathons run ranged anywhere from 5 to 1,016 marathons. I have no idea who that would be, but that's impressive. So the rate of arthritis was basically 9% in active marathoners versus 18% in the general population. So activity is a good thing. And that's the most common myth that I wanted to kind of dispel today, is that it is good to be active. Activity does not cause arthritis. Injury does potentially cause arthritis. Most importantly, as we've discussed this whole talk, is that the reason we do injections is because the cartilage doesn't have blood flow. So the best way to make an impact on that cartilage or the internal health of that knee is through an injection. We know that for the most part, arthritis is a chemically regulated process. And obesity, through mechanical, but mostly through chemical means, causes arthritis. So obesity is just generally a high inflammatory condition, and we call it metabolic syndrome. But obesity is really the root of what we clump into the metabolic syndrome, which is high blood pressure, high cholesterol, diabetes, neuropathy, all these side effects related to the high inflammatory condition associated with obesity. And we now know that has a similar effect on the knee. It causes increased cytokine inflammation, other pro-inflammatory markers in the knee, which lead to degradation of the cartilage. So this discovery was kind of happening about 10, 15 years ago when I was in residency. And I really studied it back then as far as, diet. So I have a ton of patients ask me, how can I lose weight? And it's good to lose weight from a mechanical standpoint, but mostly from a chemical standpoint for your knee. It decreases the inflammation in your body. So what I always tell patients is that you want to eat foods that are processed as little as possible. So anything that's sold in a box, a bag, or a can, and the aisles of the grocery store, to some degree, has been processed. So if you can stay around the periphery of the grocery store where they have the fruits and the vegetables and the meat and the dairy, in general, that's less processed than something you're going to buy prepackaged and, pre-made, prepackaged in a box, in a bag, in a can. So that's kind of what I don't try to push any certain kind of diet, but in general, try to eat foods in their whole form as much as possible. So what have we talked about? Hopefully we discussed cartilage and its process of arthritis. Cartilage is an amazing structure, but when it gets degraded, unfortunately, there's no regenerative potential. Everything we've talked about today, from corticosteroid, gel injections, PRP injections, and BMAC, it's trying to improve the milieu or the environment of the knee to be less inflammatory. If it's true that PRP and BMAC can actually halt the progression of disease, that is an advancement from what we have currently with cortisone and HA injections. Again, they are out of pocket. And then the biggest common myth is that if you're told you have bone-on-bone arthritis, which is how the idea of this talk gets started, you don't have to shut it down. You may have to shut it down because it's so painful, but injections, anti-inflammatory, braces, activity modification, you can be as aggressive as what you can tolerate without really doing any further damage. But at the same time, often the pain gets so severe, the non-surgical measures just don't provide as good a quality of life as we would like. And then that's when we would do a knee replacement. So what does the future hold? Without a doubt, our treatment for arthritis is going to become more molecular based. We're going to try to intervene those damaging inflammatory cytokines that get into the knee in the arthritis process. When someone gets injured, we know that there's a high level of inflammation that causes post-traumatic arthritis. To be able to block that cascade at the time of injury, hopefully would decrease the risk of arthritis in the future. There will certainly be an expansion of regenerative medicine. I don't know if we'll ever be able to truly regenerate cartilage, but again, kind of stopping the progression of disease, because we know arthritis is progressive. And then finally, I just wanted to say something about kind of the cost. So stem cells or BMACs, they are very, very expensive, $3,000 a pop. Without a doubt, a $3,000 injection is going to have a huge placebo effect. So if it makes you better, the studies would suggest that saline might be as effective, but a lot of patients get better with their BMAC injections. If it's something you have the means to pretty easily do, I don't see any harm in it. Don't be misled that it regenerates the cartilage. On the other hand, if you're pinching pennies, saving up month to month to try to afford a stem cell injection, in my opinion, with the data we have right now, it's probably just not worth that much of a sacrifice. I do think the future is bright, though, for this topic, which, again, currently is in its infancy. So I hope that helps dispel some myths and answer some questions.
All right. Well, with that in mind, thank you, Doctor. What we'll do, as I mentioned, we will, if you saw in the chat, we will add the video to the recording as we do this. But let's open it up for live Q&A. At this point, I don't have anything currently in the chat, but however, if you'd like to unmute yourself and ask a question of Dr. Briggs, please do so at this time. Yes, go ahead. I think there was a hand up. I just need you to unmute yourself and ask a question, please.
Is it me?
Go ahead. I'm not sure who me is, but go ahead. Go ahead and ask the question.
I want to ask him what he thinks of ice water baths for anti-inflammation.
Yeah, that's a great question. Ice water baths are like a huge rage right now. So, as it relates to healing from, say, a knee replacement or an injury, we are huge advocates of ice cryotherapy. We actually recommend patients get like an ice machine after they have surgery. The ice machine that we carry has compression that causes, decreased swelling, and it also delivers ice. And so, we don't really know the mechanism, but in general, we do think that it's helpful. We think it decreases the narcotic use, and in general kind of decreases the inflammation associated. I know I was really into triathlons whenever I was in medical school, and some of my riding buddies would do ice baths, and I tried one time and it was absolutely miserable. I mean, they are hard to get through, but if you can get through an ice bath and you can, it's a shock to your system. But I don't know the science behind it, to be honest, but I do think that cold is a very good anti-inflammatory.
Thank
Okay,
you.
that wasn't to dare, so can I go ahead and ask a question?
Yes, go ahead now that you are unmuted.
Right, thank you. So X-rays show bone on bone knee. Went to the doctor because I had pain after a strenuous climb. Time took care of the pain. I'd like to climb some more, but I've been afraid. What can you advise?
Yeah, so this is the patient that I see pretty much every day. So and it's important to remain active. And so I like your mentality of what can I do to remain active. So full court press, non-operative treatment for knee arthritis would be over-the-counter anti-inflammatories, Tylenol, a brace, especially if you have an alignment issue. So if you have arthritis on the inside part of the knee, your knee becomes bowed. If you have arthritis on the outside part of the knee, it becomes kind of knock-kneed. So a brace can help stabilize that and often help with weight-bearing activities. I always tell my patients, if you're going to go on a long walk or a hike, use hiking poles. So if you load up on Tylenol anti-inflammatories, you use a brace, you use hiking poles, ice when you're done, and then I would employ an injection. This topic is about all the injections. You can do cortisone, you can do HA, pay out of pocket for PRP or BMAC. That's kind of an elevated simplicity. Corticosteroids are the most simple HA, PRP, stem cell. I mean, that's pretty much all we can do is anti-inflammatories, hiking poles, braces, ice, and an injection. If that cuts it, you are doing no harm by staying active. Even though you've been told you're bone on bone, it doesn't mean you have to shut it down. But if you aren't able to do any of those activities and the non-operative management is not working, then I have pretty good job security with hip and knee replacements these days. I mean, it's just very, very hard to get 100% pain relief to the point where people are satisfied. And that's why we do so many hip and knee replacements. And thankfully they are successful.
So let me repeat, I have no pain. Why would I take an injection?
Yeah, if you don't have any pain and you are tolerating it just fine, I don't think injections are protective or preventative in any way. I would say if you don't have pain, then you don't even need to take the anti-inflammatories because those too have side effects. But sometimes a brace can help avoid an exacerbation of the pain, and I still would use the hiking poles. But we have a line in medicine that not all things that are degenerative hurt, but all things that are degenerative and inflamed hurt. So you're probably just not having much inflammatory response, which is a good thing.
Because I'm not pushing it.
Yeah,
Which is,
and if you start to push it and you have pain, then that's when we would employ some of these other
Okay.
measures. Yeah.
Okay, thank you.
But stay active.
Right.
All right, thank you, Dare. All right, let's get to a couple more questions. Feel free to unmute yourself and ask a question of Dr. Briggs. Or if you feel more comfortable, put it in the chat, but we're here to answer questions if you would like. All right, I don't see any hands up or people unmuting. With that, Dr. Briggs, do you have any final comments? As I said, we will, this is recorded and we will edit it, and then we'll get the video that we were talking about earlier into that and get it out to everyone who registered as well. But Dr. Briggs?
Yeah, no, I thank you guys all very much for your time. I know it was a little bit more of a science-related discussion than what we normally have, but I get asked questions about this all the time, and so I wanted to spend some time, both myself learning a little bit more about it, but also having a reference for you guys.
Great. Well, Dr. Briggs, thank you again for coming from surgery and getting here and helping us. This is great, and I know you're on call tonight, so we'll get you out of here and let you get back to patients.
All right.
Thank you, everyone, and we'll be talking to you soon.
Thank you.